Hi, this is Dio. This is the second lecture in the DioNavi User Manual series, The Basic Understanding of CBCT. While using the DioNavi guide, have you ever gotten the feedback from the DioNavi Center that you have to take the CT again? Here's an example. Even though there were no problems with the CT scans, intraoral scan, or the stone model, there is a merging difference of 1.39 millimeters. What do you think went wrong here? Look at this slide. This merged CBCT file and a scan file. There is a gap between yellow and red gingiva lines in the image. This is a different case. 3 markers were attached on the maxilla of the patient, and the CBCT image and oral scanned image were merged using the Implant Studio software. The merging is pretty accurate, right? However, a stone model of the same patient was scanned with the CT, and that CT image and the existing scanned image were merged together. You can see that the outline of both markers on the right doesn't exactly match. There is a 1.4 millimeter difference between the merged images. What would happen if this problem occurred while making a surgical guide for the patient? The most uncomfortable thing is that you have to call in the patient again to retake the CT. No one would want this situation. In order to produce a surgical guide, the CT image and the scanned image must be precisely aligned. Sometimes these two images don't align perfectly due to errors that occurred while taking a CT image or during intraoral scanning. And since there are so many types of CBCT, it is necessary to first understand the CBCT to reduce the errors. Today we will learn about the basics of the cone beam CT. First is the FOV size. You should check the FOV size of your CBCT because the surgery using a surgical guide may be limited depending on the FOV size. Second is deciding the bite position the patient should be holding while taking the CT. Open bite or closed bite? What's right in what cases? The third is knowing the limitations of the CT. This is because the precision of the CBCT image determines the precision of the produced guide. We will discuss these 3 topics in more detail from the next page. FOV is short for field of view. It is the size of the image taken by the CT. From FOV of 8 by 9, you can see that the entire tooth cannot be scanned. The larger the FOV size, the more information it can contain, so it can be used for more diverse indications. However, in order to prevent radiation exposure and image distortion, it is necessary to select an appropriate FOV size for each case. Let's study which indications can be applied to the 3 most popular FOV sizes. Perhaps the most used CBCT was FOV of 8 by 5 at the time CBCT began to be widely used in the dental industry. Let's study this size first. Looking at the scan image on your left, you can see that it is possible to scan from the molar to the anterior region. Considering the area for the surgical guide to be securely placed on the teeth, it can be used in implant cases of 1 to 3 units. In addition, if the treatment area is wide, 2 surgical guides must be produced for each of the left and right arches using the CT because it only shows so far. Next is the FOV size of 8 by 8. This scans from one molar tooth to the premolar tooth on the opposite side. It is possible to be applied for the case of up to 8 teeth. However, if the implant needs to be placed on both molars, you need to make 2 surgical guides. Lastly, there is a CBCT with a FOB size of 10 by 8.5 or bigger. Since this size can take an image of the entire oral cavity, there is no limitation of indication. Even for a full arch case, only one piece of surgical guide is needed. Therefore, FOB size of 10 by 8.5 or bigger size are recommended for smooth guide surgery without limitation of indication. Next subject is about deciding the bite position before taking the CT. If it is not a guide surgery, CT is usually taken with a bite close. However, if you take a CT with a closed bite, the information on the occlusal surface is not visible. So when it is necessary to merge the CT and the oral scan data, bite needs to be open. Take the CT with the patient biting on a gauze, then you can get a CT with an open bite. This page describes the case when CBCT should be taken with a closed bite. When scanning CT using radiation transmitting materials such as splint, the patient's denture, and the wax denture, the CT is distorted. Therefore, in order to obtain accurate vertical dimension and occlusal information, it is necessary to take the CT with a closed bite. You will see a simple video of the CT taking process that you've learned so far. This is a natural teeth case without any metal restoration. Next page, CT scan errors will be explained in greater detail. Finally, the third topic, limitations of CBCT scan. For accurate implant planning and guide design, accurate CT image must be obtained first. However, if the CT resolution is too low, or if an article shows up in the image, it will be impossible to use the image to produce a guide. There are some other limitations for CT that interfere with the production of surgical guides. Let's look at this picture. The normal picture above clearly distinguished bones, teeth, and gingiva. However, in the poor image below, the distinction between bone and gingiva is not very clear. This is caused by the CT's resolution being too low. If the resolution of the CT image is too low, the bone and tissue cannot be accurately distinguished, and precise merging point designation as well as precise guide production will be impossible. In this case, you need to calibrate the CT or reset through the CT maker. And there are artifacts. Motion artifacts or metal artifacts. Motion artifact is caused by the patient's movement while taking a CT, and metal artifact is caused by the metal prosthesis in the patient's mouth. What kind of artifact do you see on this slide? Yes, this is a motion artifact. Because the CT is taken while the camera rotates around the patient's head, the patient sometimes turns their head along with the CT. These movements cause motion artifacts. The main phenomenon is the overlapping of 2 or 3 images. The way to prevent this is to keep the patient's head still when taking the CT. it's important to tell the patient not to move during the CT scan. Metal artifacts are caused by metal prosthesis. As you can see in the picture, the scan around the metal prosthesis is disfigured, so it is not possible to specify the exact merging point. Therefore, the important planning process cannot be processed. We put a marker on metal prosthesis. Scan with the oral scanner and then take a CT without moving the marker. After everything is scanned, the marker can be used to align the CT image and the oral scan image. This can also be used in a splint or wax denture. Next is the horizontal dimension error of the CT image. This problem occurs when you need to scan the full arch in cases such as full mouth rehabilitation. First, let's do an experiment to understand this phenomenon. Markers are placed on the plaster model and scanned by intraoral scan and CT. And then, the distance between the two markers on the stone model is measured using vernier calipers. Scanned images and CT images are measured on the computer also. The following results are obtained: 54.04, 50.25, and 55.66. The CT image is 1.62 millimeters longer than the stone model. Since the deviation of 1.62 millimeters exceeds the acceptable value for implant planning or guide design, it cannot be processed. When merging the scanned image and the CT image, if the gap between the exterior lines of the two images exceeds over 0.5 millimeters, it causes serious errors during implant placement. Therefore, if the difference between two images overlapped horizontally or vertically is greater than 0.5 millimeters, DO inevitably requests to rescan. If a horizontal error occurs, you must check the CT image distortion using a CBCT jig and contact the CBCT manufacturer for calibration. So what's wrong with the next three images? First is a sinus case, but maxillary sinus part is cut off. The second is a mandibular case, but the mandibular nerve is not visible. The last is the anterior teeth, but you can't see the images of the antagonist. Of course, with this CT image, implant planning and guide prediction can't be done, right? In this case, you can reset the CT domain and take the CT again, including the required part. This is the last case. Look at the picture above. This is a case with a splint. The gingiva scanned with an oral scanner is shown in yellow line. The gingiva taken with the CT is shown in red line, and the inside of the splint is shown in a white line. These three lines are overlapped, but do not align, and there is a gap. The second picture below is a case of another denture. There is a gap of more than 3 millimeters between the yellow scan line and the gray CT line. In this case, can you plan the implant and design the guide? Of course not. Why do you think this is happening? This is because the splint or denture has not been correctly placed on the patient's gum. When using the CT with splint or denture, you must accurately take the CT with a closed bite. So far, you have learned the basics of the CBCT for DioNavi guided surgery. Let me summarize what you've learned so far. First, CT should be taken with an appropriate FOP size. Second, except for the denture or splint, CT should be taken with an open bite to find the correct occlusal surface and registration point. Third, the patient's head must be fixed to prevent motion artifacts. Fourth, to prevent metal artifacts caused by metal prosthesis, you can attach markers and take the CT and oral scan. And finally, In order to prevent problems caused by low resolution and horizontal errors, CT calibration is recommended in advance. That's it for today. Thank you. This was Dio.